afternoon, everyone. I'm pleased to introduce Dr. Naiim Ali, who's coming to us from the University of Vermont Medical Center in Burlington, Vermont. I'm an old alumnus of the UVM Medical School and had many good years there. And we're both East Coasters, so we have a lot of interest in common. He's going to speak to us on his interest and experience in global radiology, but just a few comments on Dr. Ali's background. He's the co-division chief and education director for the ultrasound imaging division at UVM. He's the associate program director of the Diagnostic Radiology Residency program there as well. He has served in many roles in organized medicine, both the Vermont Medical Society, the AMA, and the ACR. And he's also leading the Imaging the World implementation of point-of-care ultrasound services at rural health centers in Malawi. And also they work in quite a bit of work in Uganda as well. So I'll turn it over to you, Dr. Ali. And if people could put their questions for Dr. Ali in the question and answer box, I will direct them to Dr. Ali at the end of his talk. If there's so many questions, I may have to select some specifically, but just put your questions down for him in the box and we'll get to those at the end of his talk. Dr. Ali, take it away, please.
Thank you so much, Dr. Harris, and thank you all of you for having me for this talk virtually for this Grand Rounds. As Dr. Harris mentioned, my talk this afternoon is going to be about global radiology. Specifically, I'll talk about radiology in low-income countries and some of the challenges and opportunities of working in low-income countries. So some of my disclosures, I don't have any relevant financial disclosures. This Grand Rounds presentation is actually part of the AUR APDR Radiology Career Advancement Program. So it gives an opportunity for junior faculty to participate in Grand Rounds, which normally may not happen, or we typically junior faculty, it's harder to get invited for a Grand Round. So I want to give a big thank you to the AUR APDR for setting that up, and for the folks on this end for agreeing to host this program. I did also want to mention that I'm a member of the board of directors of Imaging the World, and as Dr. Harris mentioned, I'm involved in implementing Imaging the World Africa and Malawi. These are both voluntary positions, but just part of my disclosures here. So just to give you a background of what I'll be talking about today, through my career so far as both a resident and now as a junior faculty, I've been fortunate enough to participate in healthcare delivery, specifically in radiology, in a number of low resource settings, including in Uganda, Malawi, Namibia, and Cambodia. And I think, hopefully over the course of the next 45 minutes or so, you'll see that every site has their own unique challenges, but there are some common problems that arise with implementation in different low resource countries. So I hope to be able to share my experience and give some case examples, and hopefully that will help any of you that decide to participate in global radiology efforts. So I wanted to start the talk by just giving you an anecdote. So this is actually an article from a newspaper in Malawi. It's a national newspaper in Malawi called the Malawi Post. And as you can see, the article talks about a blackout which killed 2 pregnant women at a hospital in Mangochi, which is one of the rural parts of Malawi. So these 2 pregnant women came in on the night of this February 8th. Unfortunately, the doctors were unable to save the life of the women. They talk about there being a power outage that possibly contributed to these deaths, but really the issue was they came to the hospital too late. And so I just want in the next course of the 45 minutes, I want you to just kind of just think about that and the sort of issues that come up with healthcare delivery in low resource countries, and we'll come back to this at the end of the talk. Through my travels, I've been very fortunate enough to see a lot of different animals. This is from a location in Uganda, an island in Lake Victoria. It's given the nickname Chimp Island. The newly born chimps, they actually keep separated from the rest of the family. And so this is a picture of that newly born chimp. All right, so thought I'd start by just giving you a little bit of a background on Uganda. So Uganda is a nickname for Uganda is a pearl of Africa. It's actually one of the poorest countries in the world. It ranks 164 on the Global Human Development Index. Maternal and child health is one of the highest burdens of illness, and actually the leading cause of death for girls under the age of 18 and women of childbearing age is pregnancy in Uganda. In Uganda, the way that the healthcare system is set up, and I use this as an example because it's actually very similar in a lot of different low-income countries, particularly in sub-Saharan Africa. So typically the way this is set up, the healthcare system in total is overseen by the Ministry of Health. And there are several commissioners that report to the Minister of Health. There's usually both a public and private sector. The private sector is mostly run by religious organizations. They are allowed to charge patients nominal fees. And most of those organizations receive healthcare subsidies from the Ministry of Health. And the government sector, which is usually the larger provider of healthcare in these countries, they're not allowed to charge patients anything. They receive either monthly or quarterly funds from the Ministry of Health. And they're usually seeing the vast majority of patients in those countries. And so in Uganda, the way it's sort of set up, the hierarchy of healthcare, the primary care or village level health happens at the health center. And then if there are issues at the health center that can't be dealt with locally, those patients get transferred to the district hospital. And then if there are issues that can't be handled at the district hospital, they get sent over to larger hospitals, which are the regional referral hospitals. And then the kind of end all be all, at least in Uganda for hospitals, is Mulago National Referral Hospital, which is a 1,000-bed hospital in Kampala. And so Mulago National Referral Hospital, again, is a quaternary institution. This is the only hospital pretty much in Uganda for subspecialty level care. And it typically only accepts referrals from regional referral hospitals. So again, if there's a problem at a health center at the rural level, you kind of need to go through the hierarchy to get to Mulago National Referral Hospital. They do have a radiology department there, much smaller than what you'd imagine for a 1,000-bed hospital, but they do provide some radiology services, and I'll go into that a little bit later as well. Regional referral hospitals, there are about 10 to 15 of these scattered throughout Uganda. They're intended to serve as a referral site for approximately 10 district general hospitals. These are usually staffed by about 2 to 3 physicians who have completed residency training in a medical specialty. Otherwise, there are what's basically the equivalent of an advanced practice provider. So what we would think about as like a PA or an NP. Most have X-ray and ultrasound services, but none of these hospitals, at least when I was there a few years ago, had a radiologist. So any imaging that's done is just being interpreted by the clinician who orders the study. District general hospitals. So Uganda is divided up into 120 districts. They're similar to what we would think about as counties here in the US. Each district is mandated to have a district general hospital, but there are, at least a few years ago, there were several districts which did not have one. Most are staffed by physicians who have not completed only an internship. So they don't have any subspecialty or additional training. And most of these hospitals, or a good portion of these hospitals, have no imaging service, no radiology capacity. Health centers are the sites of primary care, and these exist at the rural kind of village level. In Uganda, these are divided up into 4 different kind of levels of health centers. There are health center 4s, which are the kind of the highest of those levels. They perform basic surgical procedures, and in Uganda, that's considered C-section and exploratory laparotomies. So again, these are a lot of times physicians who have only completed internships who are performing these procedures. Health center 3s are overseen by equivalent of an advanced practice provider. They do have capacity to admit patients overnight, and they perform vaginal deliveries, but they don't perform any other procedures. And then health center 3s are usually overseen by a nurse. Health center 1 actually refers to the group of community health workers. These are usually just people who have received minimal training to answer questions like about basic hygiene and important vaccination. So, the way the healthcare system is designed in Uganda, and again, this I think is analogous for a lot of the rest of sub-Saharan Africa, it's really meant to be a system that's predominantly government run and should be free for all citizens of Uganda. Unfortunately, in practice, in the practice of implementation of these services, the facilities are usually extremely lacking in resources. As I mentioned, most of even the bigger hospitals don't have any radiology services. The healthcare providers who are working there are not technically allowed to charge anything to their patients, but kind of under the table, a lot of these providers either expect some sort of compensation or have their own private practices where they're supplementing income that they're getting from the government. In the government sector, these institutions, these facilities are given a quarterly stipend to manage the expenses of running that facility. In most cases, that stipend doesn't actually cover all the hospital expenses. The private sector in Uganda also has, kind of runs this analogous parallel system. It also has some general hospitals and health centers. Private sector, they're allowed to charge with quote unquote unreasonable fees. The salaries of the healthcare providers are usually provided by the organization that runs the center, and more often than not, that's a religious organization. The private health facilities are eligible to receive some subsidies. In Uganda, that's called the primary healthcare program. This is a picture from ISHASHA, which is in the western part of Uganda. ISHASHA is famous for lions that like to climb trees. So these are some of the tree lions in Uganda. So one of the big issues in Uganda is the disparity of healthcare providers and access to healthcare. So in Uganda, about 90% of the population lives in rural areas. And so that's pretty much anywhere outside of the main city and the capital city of Uganda, which is Kampala. Most of the additional areas are quite rural, and that's where 90% of the people in Uganda live. Unfortunately, 90% of the care workers all are located and practice in Kampala. And so you have this disparity where 90% of the healthcare workers and only 10% of the population lives in the city, but 90% of the population and only 10% of the healthcare workers live in the rural areas. And so that really puts a strain on healthcare delivery in these rural settings. And so, a lot of people, including folks from the United States and other organizations, kind of recognize this being a problem and have tried to address that. Unfortunately, in my experience, it's can be very hard to do that. So I'll give this example, and I'll use Rotary Club as an example. I'm actually a Rotarian, so I can, I'll kind of be mentioning kind of the negative aspects of this, but I think, by the end, you'll see, why that's the case. So Rotary Club had this idea of implementing ultrasound machines at rural healthcare sites, so health center floors. So they donated, they bought this equipment, this ultrasound machine. They donated it to this health center, which was located in a rural part of Uganda, the Walukuba Health Center. And what ended up happening, they left that there. They mentioned, they kind of worked with the providers there and kind of let them know that they were going to be donating this. They came back several months later, and this was collecting dust. No one had used this in the course of several months. They hadn't even turned it on for the most part. And so I think this just highlights, some of the problems that happen when there are well-intentioned and sometimes even well-funded organizations that are interested in doing work in these countries, but they ended up spending a lot of money, for example, to buy ultrasound machines, but then it ends up not getting used. And so understanding that this being a problem back, about a decade ago now, the chair of the department here, Kristen Distichter, along with one of her colleagues, Brian Guerra, established an organization called Imaging the World. And so the goal of this organization is to provide sustainable ultrasound resources to rural communities in low resource settings. It's a registered NGO in both the United States and in Uganda, and it works closely with the Uganda Ministry of Health. Most of the funding for the organization is through foundations, industry, and some private and other research grants. And so the idea behind Imaging the World is to try to figure out what are some easily treated conditions that can be relatively safely and easily being diagnosed at the rural sites. And so, one of the kind of low-lying fruits for this is pregnancy, right? There are a lot of pregnancy-related complications. As I mentioned, pregnancy is one of the highest causes of death amongst young women and girls. And so, there's a huge potential for preventing these deaths. And the kind of the other part of it was we have technology, namely ultrasound, that can identify some of the earlier, relatively early, identify some of the complications of pregnancy. So things like breech presentation, placenta previa. These are relatively easily diagnosed conditions on ultrasound, but if we make the diagnosis before they end up going into labor, we can actually have an impact on patient care and improving health outcomes. And so the way we approach this from an Imaging the World standpoint is we identify sites, health center 3 is most of the time, where there are, again, already existing clinical officers, nurses, and midwives, and we empower these clinical officers to provide this ultrasound service. So we identify these sites, we conduct an 8-week-long course in theory and didactics that includes some hands-on skills. Usually that's done at a centralized location, and then they go on and get some more training on site at their own clinics. And then we have a system of proctoring so we can continue to monitor how they're developing as sonographers, and that also includes on-site training. The push for this program since its adoption, about 10 years ago now, is for it to be completely sustainable. So now, we're talking about, I just mentioned to Dr. Harris, actually, we're gonna have 7 new sites in Uganda. All of the training that's being done at those 7 sites are by Ugandans. So it's people who started in the program 10 years ago who became, now expert sonographers. They are the ones who are training the new people who are getting involved in the program. So again, the idea is to create a sustainable process that's all within country in Uganda. Another, part of this program is a quality assurance process. And so, as you can imagine, if you're a nurse midwife out by himself or herself, capturing these images and trying to make these diagnoses, there might be times when you have questions about the diagnosis, or there's always questions of are they providing high quality imaging and reports? And so to address this, we created a quality assurance program. So in addition to any ultrasounds that providers may have questions about, additional random studies are transmitted through a proprietary software through the Cell service. And those are transmitted centrally into, in our case, Kampala, where there are more expert sonographers that can look at those cases and answer questions as needed, and then also serve in that quality assurance capacity for those randomly selected cases. So again, this allows for means of ensuring quality, and also for the providers to be more comfortable performing ultrasound when they have questions that come up. Another important component of the program is community outreach. So as you might imagine, these are very rural areas that we're going into in Uganda. A lot of them, the patients that we're interacting with are, not very familiar with ultrasound, or have heard things that are not true about ultrasound. There's a lot of myths in these rural areas that ultrasound could cause burns or birth defects. And so, a lot of the work that I did when I went there several years ago was just doing community outreach. So, we had folks come into the health center that were the community health workers. We gave presentations to them. At one point, I was actually even going door to door in the village and talking to patients about ultrasound. And again, this is a hugely important piece of this, because you can put all these things in place in the clinic, but if you don't have patients that are interested in receiving these services, all your efforts are really for naught. So again, this is a really important part of the process for us. One of the things that we kind of realized early on is that while we were told that a lot of patients or the people who live in the village understood English, it by no means was their first language. And so what we decided is to actually first hire a translator, but also to translate all the slides that we're using into Luganda, which is a native language there. And so this was a project where we're looking at rheumatic heart disease. So we were just explaining, like strep A pharyngitis in this case. So we just made sure that we had all of our slides translated into the local language. This is a picture of hippos. This is from Queen Elizabeth National Park, which is also in the western part of Uganda. So I've talked quite a bit about, kind of the rural sites and how radiology is practiced, or how we're implementing practice of radiology in rural sites. I'd like to take some time now to talk about radiology and the practice of radiology at tertiary hospitals. So to do that, we'll move a little bit further south from Uganda to Malawi. Malawi, the nickname of Malawi is the heart of Africa, warm heart of Africa. It has an even lower GDP than Uganda, and it has an even lower ranking in the Global Human Development Index. The death rate related to pregnancy is one of the highest in the world, about 1,100 per 100,000 patients. And it has one of the highest rates of stillbirth deaths in the first day of life in the world. Malawi is, an incredibly poor country. They, very much lacking in resources. Standard, kind of living accommodation is something like this on the top right here. A lot of patients, a lot of citizens of Malawi are, kind of just getting by day to day. This is a group of folks that, rely on chopping down wood and creating charcoal for their, kind of livelihood. So again, a lot of people are just sort of surviving day to day in Malawi. So interestingly, another kind of thing that kind of fits into this is the material girl, or Madonna. So as you may have heard, if you're kind of keep up with pop culture, several years ago now, probably several decades ago now, Madonna had adopted 2 children from Malawi. And so as a result of that, because of, her adopting these children in, I think it's going to be, 2017, one of her birthday presents to her children was actually the creation of a pediatric surgery and intensive care center, the Mercy James Center. So as you might imagine, a lot of resources were put into developing this. They created a pretty nice facility there. What they didn't do is think about the ultrasound or any radiology equipment there. So, when we visited there, they had this one machine, which I think they had gotten from a private donation. It was from the 1980s, didn't have Doppler. The image quality was very, very poor. They only had curve probes. And again, this was at a pediatric hospital. So really, they really needed a high frequency transducer. And this was non-mobile. They couldn't move this. So the patients had to come to the ultrasound room to get scanned. So kind of identifying this, we work with an organization called Warm Hearts Foundation, which is actually based in Michigan, to donate a more modern ultrasound machine. And you can see that that's what they're using here. This is one of the pediatric surgeons that practices, pediatric surgeons that practices at the Mercy James facility. And then we'll keep moving south to Namibia. The kind of nickname for Namibia is the land of the brave. Namibia, unfortunately, has a very violent history. There were German colonizers who committed actually pretty atrocious genocide there in the early 1900s, which killed about 80% of the Herero and Namakwa populations. It was occupied by South Africa during the apartheid times. And now, as a result of all these atrocities that were committed in Namibia, there's huge disparities in economics between the urban areas and the rural regions. It's actually one of the least dense countries in the world, as most of the country is actually the Kalahari Desert, so a very spread out population in Namibia. So Namibia has only 2 government hospitals in Windhoek. One of the 2 is KATUTURA State Hospital. Historically, during times of apartheid, this was served only Black patients. Obviously, it's kind of opened up to everyone. But KATUTURA Hospital is definitely the hospital where folks that can't afford to pay for healthcare services end up coming to. Their radiology department in KATUTURA Hospital has one 16-slice CT scanner. They have a fluoroscopy unit, a couple of DR units. They don't have any ultrasound in radiology. It's all done by just other clinicians in the hospital. They do technically have a PACS, but at least the time I was there, it wasn't working. They have one radiologist who works in the hospital. It's Dr. Finn, who's right here, Dr. Edward Finn. And so everything that, any imaging that gets done in the hospital is reviewed by Dr. Finn. He actually handwrites reports. Those reports, along with the printed out copy of the imaging, gets given back to the patient, and they take the report back to their provider. And again, that's kind of common, at least in my experience, in a lot of places in sub-Saharan Africa and other kind of low-income countries, right? They don't have access to PACS. A lot of times, even getting digitally saved imaging can be difficult. And so what ends up happening is they end up just printing these studies and then handing the report and as well as the imaging study itself that's printed out to the patient, and then they take it with them when they go see their provider. So one of the kind of interesting problems that came up both in Namibia as well as in Uganda is that even though they had this CT available, their volumes of imaging was very low. Sometimes only a couple CT scans done a day. And again, this is for potentially a 1,000-bed hospital. And so we were kind of thinking about why we had such a low CT volume. So some of the thoughts we were thinking was maybe the attendings that were practicing there, they weren't trained when there was CT available, so they weren't used to ordering CTs. A lot of providers were unfamiliar with imaging and therefore didn't really consider it in their diagnostic or management workup. Even though there was a CT there, a lot of times if the power was out or if a part wasn't working, it wouldn't be available, and so they were just used to not having it available. And then the other thing was a lot of times, because their staffing, including for technologists, is pretty limited, CT wasn't available outside of normal business hours. And so, could kind of address these questions. Actually, we were approached by one of the radiology administrators in a hospital in Uganda to actually talk to the non-radiology providers in that hospital about increasing their CT volume. And so the way we actually approached this is actually using the ACR appropriateness criteria. So you all are probably familiar with this to try to decrease imaging utilization. In Uganda, we were actually using the ACR appropriateness criteria to increase our imaging utilization. So we used some of the criteria and develop a lecture based on this to talk about some of the times, for example, head trauma, why it's appropriate to get a CT head in those cases. Even if at the time of evaluation, the patient may be doing okay. So we kind of developed a whole lecture based on the ACR appropriateness criteria to try to improve imaging utilization. So this is the grand rounds we set up. We had providers, internists, neurologists, orthopedic surgeons, medical students who all came to this grand rounds. We conducted some surveys to figure out their knowledge and sort of their expectations and what they were thinking about when they were thinking about ordering studies. And then these are some of our results. You can see that there's kind of all over the board here in terms of what they were using to figure out whether they needed to order a study or which kind of test to order. And then they, afterwards, we kind of asked them if there's anything that they think might help. And so we're interested in looking at whether potentially some sort of clinical decision support tool like we have available now more commonly in the United States here, whether that would be helpful to their practice. So, again, an ongoing project, but something interesting that we kind of came across, this sort of idea of underutilization of imaging. This is a picture of an oryx. This is a national animal of Namibia, and this is in a part of Namibia called Sossusvlei, which again is a part of the Kalahari Desert and is actually one of the most driest places on Earth. So for the past half an hour or so, I've kind of gone over some of the projects that we've worked on in Uganda, Malawi, and Namibia. I'm going to take the next 15 minutes or so to really highlight some of the lessons that I've personally learned and hope that you can kind of learn from my experience, so that if any of you end up working in these rural settings and low resource countries, you can kind of take that with you. So the one thing that we talked about already is kind of this concept of understanding the patient population, right? So really getting a sense of who your patients are, right? We were told when we went into this one site in Uganda that all the patients there speak English. And what we found is, well, yes, that was true. That really wasn't their first language. And so, we kind of had to adapt how we were interacting with patients as a result of that. So things like religious affiliation, sources of income, the languages that they're spoken, literacy rates, these are all impact how you deliver radiology care in that community. Another important question to ask is who makes the healthcare decisions? So with Imaging the World, primarily we were doing obstetric ultrasound. So we just assumed that it would be the women who were coming to get the scan that would be, kind of deciding the healthcare for themselves. What we quickly learned that it was actually the husbands who were kind of deciding whether their wives could even come to the clinic to be seen. And so engaging, all parts of the community to make that possible was an important step. So, kind of making sure that you understand who the patient population is and kind of tailoring your service to that population. As I mentioned before already, community outreach is very important. A lot of low resource countries, including in sub-Saharan Africa, already have existing community healthcare worker programs. And these people are, already there on the ground, kind of engaging patients in for different healthcare needs, including for vaccinations and things like that. So, we were able to harness this group that already exists and kind of get them to get involved in our ultrasound program. A lot of patients actually rely on traditional healers for either a portion or all of their care. Sometimes that's at odds with modern medical practice. So, one of the things that we actually did in Uganda is we met with some of the traditional healers and talked about our role and how we can, what role we can play in the management of their pregnant patients. As I mentioned, it's important to, if you're using any resources, to kind of make sure that those resources are things that they can use, including whether that's translated into the local language. Provider outreach is very important. So, at the tertiary level, obviously we want to make sure that the providers who are going to be our referrers, who are going to be ordering these imaging studies, understand what imaging studies are available and when to utilize them. The example I gave of this, using the ACR appropriateness criteria as a tool for increasing the volume of imaging can be helpful. But just getting a sense of what the providers are looking for from radiology and what their hesitations might be is also an important part of delivering care in the tertiary setting. Then, as I mentioned, right, there's the complexity of the healthcare system, depending on the country you are, can be very variable. And rather than trying to work against, kind of going off on your own and doing your own thing, I think what's really more important is to try to understand how the healthcare system works, and then figuring out a place where in that healthcare system where it would be valuable for you to contribute. And so, obviously, even when you're not there, there are folks that are participating in healthcare delivery in Uganda. And so to be able to create a system where, the programs and the projects that you implement kind of build into the existing healthcare system hierarchy, make sure that you're working in places where they actually need, the services that you're providing is very important. And then also understanding the sort of hierarchy of, the sort of district, state, and national levels, and making sure that you, kind of partner with the people who are in charge of running the healthcare in those settings, right? So, you don't want to be in a healthcare center and then, months later, is the first time you're meeting the person who's in charge of healthcare delivery for that district, right? Because then you're creating situations where they might be doing work in parallel, or even doing work that's kind of that they're repeating. Instead, you want to kind of understand what they're dealing with, where they see the needs, and kind of build your project to work within that capacity. It's also important to understand that there are going to be infrastructure problems that probably exist especially at the rural sites. So most of these rural centers that we work at don't have running power. Almost all of them don't have running water, and so they rely on typically solar panels for their power supply. This is one of the facilities in Malawi and Naiim, which is again a rural part of Malawi. So they were actually basically using spare car batteries for their sites of storage of power. In Malawi and Uganda, they both have quite long monsoon seasons, and so they get very little sunshine during those seasons, and so power becomes a really big issue during those months. A lot of these places can be very challenging to get to. I'm not sure if this video is going to work or not, but this is an example in Malawi where we actually had to cross this a little stream here, and this was the bridge that was crossing that stream. And so you can imagine that if you aren't able to get to the clinic, that kind of makes it very difficult to be able to provide the services that I've talked about there. So kind of understanding this infrastructure problems, and that may be an extra investment of buying a solar panel, buying batteries, even potentially building a bridge to be able to provide a healthcare service to that community. Another thing that's kind of important to understand is most of these places at the tertiary sites are practicing radiology without PACS. So in Namibia, as I mentioned, Dr. Finn is the only radiologist at several hundred bed hospital in Windhoek. He reads most of the CT scans and radiographs through a view box, right? So he gets these. This is a head CT, for example, that got printed out. He's looking at this on a view box and then hand writes these reports. So understanding what that means for these radiologists and how we can work in that system. Other hospitals where they don't have radiologists. So this is an example of Mubende Regional Referral Hospital in Uganda. The way that sometimes they can't even afford to print the X-ray, right? They don't have the budget to afford the film. Then what ends up happening is this is, I think, an orthopedic resident who came by to literally take a picture of the X-ray with his smartphone so that he could show his attending. So very different way that radiology is used and accessed in these low resource settings. So kind of understanding that is important. It's also really important to have really engaged local partners and champions of the program. So ultimately, the success of a program is going to depend on the people who actually live and work there being invested in the program. And the people who practice in the community being served, they're really the people who are going to determine the success of the program. And so meeting with those people before implementing radiology services is extremely important. And then at the tertiary level, kind of working with leaders who are involved in delivery of care is super important. So they can kind of guide, they kind of have a better sense of where these services are needed from a kind of a higher level approach, and can sort of guide you to where your limited resources can be most useful. So this is an example in Malawi. Namwera is one of the clinics in a rural part of Malawi. This is the advanced practice provider there, and one of the nurse midwives there in the top right image here. And there, it was important to engage both of them during, when we were setting up our first sites in Malawi, to make sure that they were on board, they were interested in the project, and that they would be the champions of the project. Obviously, the team from the US and Uganda that came to implement this, we were only there for several weeks. So, the rest of it really depends on the local providers really being engaged and interested in the project. And then on a national level in Malawi, we've been fortunate enough to work with some of the national leaders in healthcare. So Dr. Louis Gadama is actually the chair of OBGYN at the biggest academic center, University of Malawi, which is based in Blantyre. And this is Anne Foya, who was the former president of the Association of Midwives in Malawi. And so, having partners like that is extremely important to be able to accomplish the things you're setting out to do in these settings. As I mentioned already, it's also important to have quality assurance, just as it is important here in the United States. So as I described, Imaging the World's model kind of includes a system to be able to transmit point of care ultrasound images. And this allows for concordance checks, right? And so this creates a sense of security for not only the people who are imaging, but also for the patients to know that, someone else who's an expert is kind of available and looking at the images as well. And this has been incredibly important when we've approached folks like at the Ministry of Health, or when we're looking at for additional funding from other grant organizations, to be able to get additional resources to expand these programs, to show that we're kind of interested in and really closely tracking the quality of the imaging that we're providing, and have a robust system to do that. Continuing education is also very important. After establishing a radiology practice, the people who are at that practice are often the only radiology practitioners, either at that clinic or hospital, sometimes even in their region or even in their whole country. If at all possible, if you're working with someone from a tertiary center, it's great to set up some sort of process where you can provide peer consultations to them. So just like, when we have a tough CT scan or MRI, we have access to, potentially a lot of our colleagues in the same division or in different divisions who we can kind of get opinions from. A lot of folks in these low resource countries, they don't really have access to that kind of, that group of colleagues, because they may be one of very few radiologists practicing in the whole country. We've sort of come up with ideas to try to supplement their ability to have that peer consultation. We were in the works of developing some sort of a joint interesting case conference. So interesting cases from here in Vermont, and then interesting cases that they might have in Uganda, and then try and find a time to be able to show those collaboratively between the two sets of residents. We're still working on implementing that. And also trying to develop continuing medical education that's relevant to the care that's being delivered there. So any of you who may have worked in, and perhaps Dr. Harris as well, who have worked in these low resource countries, probably this is a familiar sight, right? Not infrequently, I get WhatsApp messages from folks in these low resource countries asking for my opinion on different studies. And so just knowing that, and understanding that there is this huge need for this kind of peer consultation service, I think is really helpful as well. And then establishing financial sustainability. The kind of fortunate and unfortunate thing is there's usually quite a bit of money for new projects, but there's usually not a lot of grant funding available for maintaining existing projects. And so understanding that when you start is really important, right? So, if you need several $1,000s each year to be able to sustain for example, an ultrasound service, you need to figure out where that money is coming from, because that initial grant, well, it's great to be able to establish that service. It's not going to provide anything for, 5-10 years down the line. And so, coming up with strategies for, ensuring sustainability, whether that's reaching out to the local Ministry of Health, who may have limited budgets, or even, finding novel areas to develop some sort of, revenue generating component of your project is really important. So, thinking about all this, what are the day-to-day costs, ongoing costs of maintaining a project is really important, even at the start of the project, so that you can make sure that you've thought of this and have a plan in place for that. Also remember that from a national perspective, right? So for example, the Ministry of Health in Uganda, the Ministry of Health in Namibia, or Malawi, they have really, really tight budgets, right? They're have a lot of patients that they need to provide care for, a lot of services they need to provide. And so asking for money for them is going to be really, really challenging. And so, just keeping that in mind, and, having processes in place to kind of engage with these different funders is really important. So these are some of my conclusions. So, hopefully in the past 45 minutes or so, I've shown you that there are a lot of challenges associated with implementing radiology services in low-income settings, and most of them are unique to each different project, but there are several kind of common threads that emerge as you work in these different settings more and more. Unfortunately, good intentions and funding alone are not enough, right? As I showed that example of that Rotary donated ultrasound machine in the rural clinic in Uganda. Having these deep pockets and good intentions is usually not enough. You really need to have a good plan and really carefully consider what you're implementing. It's really important to recognize and mitigate some of the anticipated and unanticipated issues, so that you can kind of work with those issues and make sure that your project is still sustainable. And then I think one of the funnest parts of doing global radiology work is actually coming up with those solutions, right? So realizing that you have a very small budget, realizing that maybe there isn't power for 3 months of the year, right? And how can you work around those issues to come up with a solution that works for that community, for those patients. So it can be just incredibly rewarding. So we started out, an hour ago, or I guess 45 minutes ago now, talking about this kind of anecdote and this, and I think this highlights some of the major issues that occur in these low resource settings, right? We have a case where there were 2 pregnant women, which, if they came into pretty much any healthcare facility in the United States, probably would have been alive after this, this issue, right? So they presumably had some sort of problem with progression of their pregnancy. And unfortunately, those 2 patients died that night as a result of, a multitude of issues related to, the low resources available in that setting. But I'd also like to leave you with a different anecdote. And this is at Mercy James Hospital in Malawi. And so this was soon after we had donated that ultrasound machine. And so what happened was this patient, this young little guy here, he came in with some severe abdominal pain. They were able to do an ultrasound pretty quickly with the equipment that we had donated. They were able to actually diagnose ileocolic intussusception. And then the pediatric radiologist who happened to be visiting during that time under ultrasound was able to do a water enema, which potentially saved that patient's, having to undergo surgery and potentially that patient's life. So, there is a lot of opportunity to really impact patient care here, even with, something as small as teaching someone how to use an ultrasound machine and having the ability to be able to donate an ultrasound machine. So that's pretty much all I have. These are my references, and I'm happy to take questions. I see that there's already one on the Q&A here. Again, thank you so much for the invitation for this Grand Rounds. I do also want to thank, again, the AUR, APTR for making this possible. And giving opportunity for people like me, junior faculty, to be able to participate or give these type of Grand Rounds, and then also to Dr. Marks, Dr. Harris, Dr. Fong for setting this up and making this possible as well.
Well, thank you very much, Dr. Ali. That was a wonderful, very informative and inspirational talk. And I'll now read the question that Dr. Ryu, our chairman, posed. He said, "Thank you for an excellent talk. I want to turn the tables a little bit. Many of our efforts are rightly focused on bringing modern resources to low-resource countries, as you've shown. But could you share anything that you've learned from your experiences that illustrate the resourcefulness of Namibian or Malawian people? I'm sure they have to be very inventive given their limited resources. Do they have strategies and techniques that you think we can reasonably or safely co-opt to help us conserve resources as well?"
Yeah, that's a great question. From a radiology perspective, I think that's a very tough question to answer, mainly because there's just not a lot of radiology being practiced in these places. I think one of my takeaways was there's a lot of patients being cared for in these places without a lot of imaging, and so when I come back here and we're getting potentially every patient that's coming through the ER is getting multiple CT scans and radiographs, I kind of wonder, do we really have that much better outcomes compared to these places where they're not using a lot of radiology? So, I think that question of utilization really drives home when we sort of think about that. So yeah, I think from a radiology perspective, that's a very, very challenging question to answer. In general, I think, the things that they do really, really well is being able to see a large volume of patients. You'll be shocked, they're seeing at a, pregnancy clinic, they're seeing sometimes like 40 patients in a day, which I don't know anyone here who, signal providers who are able to, just have that kind of turnover for patients. So, I think they have a very efficient system of getting patients in and out. Obviously a lot of that is also related to, they don't have to deal with figuring out billing and things like that. And so I think those are some of my takeaways. It's just developing, an efficient way of seeing a lot of patients is really one of the keys there.
Thank you, Dr. Ali. I have a question for you, and it's, I'm kind of at the end of my career or nearing the end of my career, and you're just sort of starting out. So that's encouraging to see. But what do you tell all these young trainees or medical students or residents who are clearly interested in global radiology? And I think we have a significant core of people here at USC who are interested in global radiology. But how do you tell them with this pandemic that's seemingly going on, for a significant amount of time, certainly in Africa and Asia and South America, it's still in its worst throes, I think. And, the chances of traveling there in the next year or two look pretty slim to none, I would say. So how do you tell people to stay involved, and do you have any techniques for having people stay involved and integrated into the efforts that you're leading?
Yeah, great question. Yeah, so I can tell you a little bit of what we're doing in Uganda and Malawi. As I kind of mentioned to you before we started this talk, we're about to expand into 7 additional sites in Uganda and 3 additional sites in Malawi. And, we're fortunate enough, being in imaging the world, that we have this group of experts who started out in our program, 10 years ago now, who are now training the next generation of sonographers in Uganda. And so we kind of pretty much heavily relied on those people to be the champions for developing these programs. So I think the more I've gotten involved in this, the more time I've spent in this, I realized that the less hands-on that we are from the United States and trying to micromanage things, probably the better. So if you can create a system where the folks in country are really invested and interested in the project, I think that's really your best bet. So for starting out, for someone who's kind of interested in doing this, whether they're medical students or residents, I think getting involved with organizations that are already established, I think is one really good way. So I know RADA does a lot of projects all over the world. We obviously love to have people get involved in imaging the world, if that's something you're interested in. So I think that's definitely a part of it. I think the other thing that's, that we've been working on, struggling with a little bit is, the sort of game changer is, the access to things like Zoom and other virtual technologies, right? The trouble in a lot of these places is the internet access can be very, very spotty or sometimes very expensive. And so, that's one of the challenges we're dealing with. But once you are able to, or, find a way to overcome that hurdle, then I think that opens up a ton of different opportunities, right? We can do all of our training potentially virtually, even for things like teaching how to scan, how to interpret ultrasound, but even on the tertiary level, right? Giving conferences to radiologists in Uganda and Namibia, places like that. We had, as I mentioned, had talked about potentially starting a like an interesting case conference where cases would be submitted from both Uganda and Vermont, and we'd have residents from here and there both look at these cases and try to sort through those cases. So I think with as internet access becomes more and more readily available, I think that's where we're going to see a lot of global radiology turn to. Another thing that I mentioned, right, is this idea of peer consultation. I think there are a couple services out there that make it relatively easy to upload DICOM images, for example, into a cloud-based system. I think a lot of my experience, a lot of these places, even going that basic step of getting DICOM images uploaded onto that cloud-based system can be challenging. So I think for those of you who are kind of more IT oriented, thinking of solutions that, to make it possible for folks in Uganda and Namibia and Malawi to be able to upload images and get, peer consultation would also be incredibly useful. There's a lot of opportunity to build something there as well.
We have one last question from Daryl Huang. He says, I saw that the PACS systems were barely, if that, functional. Is there work looking at cloud PACS? Although this goes back to the internet access though.
Yeah, that's a great question. Yeah, unfortunately. So interestingly, in much of Uganda and Malawi, even the most rural areas where they don't have any, power or running water, anything like that, if you take out your cell phone and you look at it, you'll see that there's like 3 or 4 bars, right? So they have a lot of, they have very good coverage from a cellular network perspective. Unfortunately, that's just very expensive in most cases to access. So I think that there is a lot of potential there to, even if they don't have wired or, some kind of fiber optic connection, there is, this opportunity to use cellular networks and transmit data that way. We actually do that in our, quality improvement, quality assurance process. But obviously, that's much slower and potentially it's a lot more difficult to transmit large files that way. But I do think there is potential for, coming up with a cloud-based system. We had even looked into actually potentially with grant money, paying for a fiber optic cable service to provide internet for, one of the largest hospitals in Uganda as part of, our educational grant. But, again, these things are challenging to implement, and they have issues with making sure that those stay, are up and running throughout, and maintaining those networks can be challenging as well on their side.
Okay, well, it's 1 o'clock here. We probably have to wrap this up. Any other imminent questions out there we haven't addressed from our trainees, med students? Well, Dr. Ali, I'd like to thank you very much for your wonderful talk and your inspirational message to all of us. And hopefully in the next couple of years, we can get back out there on the global circuit and start doing our work in person, because as you know, and I know, being there is over half the fun, I think.
Definitely. Thank you so much again for the invitation and having me.